This is the first part of a two-part webinar series to be hosted by the Office of Minority Health and Equity. Today's focus is going to be on flu, while the second, which will take place sometime in January of next year, will be on COVID vaccinations. The series has been necessitated by a phenomenon long experienced by diverse communities, but truly stoked by the intersecting injustices to the point that we've seen unheard of levels this year. We are now looking at something that we refer to as a phenomenon known as the BIPOC paradox. The irony is that BIPOC communities, or those identifying as Black, Indigenous, or persons of color, experiencing the most disproportionately severe health challenges, hold the highest degree of understandable vaccine hesitancy. We literally find ourselves standing between history and hope. In response to this paradox, it's the goal of today's webinar to inform, to empower, and to motivate these BIPOC communities so that they may make choices about flu vaccinations with confidence. This goal supports the Office of Minority Health's equity-driven, overarching mission that is to ensure that the most vulnerable and/or underserved among us achieve and maintain good health. So, let's kick this event off, and to do so, we'd like to try and get the consensus of our guests. If you would please, we'd like you to take part in the first of two polls. And the question reads, how soon after receiving a flu vaccination are most people's immune systems ready to fight the flu? Is it immediately, within 24 hours, after 2 weeks, or never, because flu shots are not reliable? Please enter your answers now. It looks like the majority of our participants, and we've got about almost 50 folks on the line right now, identified 2 weeks. And I think if I turn to my expert panel, you would agree that that answer is correct by a show of head nods. Give yourselves a round of applause. Well, I'm certain that there's still so much more for you to learn on today's webinar, and to that point, we're going to go forward. And to ensure the most meaningful experience possible, we've decided to proceed with the assistance of a moderator. This person is affiliated with an organization recognized for its impact on diversifying the medical workforce. Founded during a time when the American Medical Association was not very inclusive. It is my pleasure to turn the reins of this event over to our capable moderator, Ms. Paulina Awuha, who will tell you a bit more about the Student National Medical Association and then go on to introduce our first speaker.
Thank you so much. Hello, everyone. My name is Paulina Awuha, and I am a second-year osteopathic medical student at Touro University, Nevada, College of Osteopathic Medicine. And like Tina said, I'm the chapter president of the SNMA chapter at the school. And SNMA, the Student National Medical Association, is an organization committed to supporting current and future underrepresented minority medical students, addressing the needs of underserved communities, and increasing the number of clinically excellent, culturally competent, and socially conscious physicians. One of our goals is to serve as a credible and accurate source of information relevant to minority issues in the field and medical education. So with the honor, I'm able to introduce our keynote speaker, Dr. Trudy Larson. She's the professor and founding dean of the School of Community Health Science at the University of Nevada, Reno. Leading a school dedicated to public health and improving community health extends her passion for improving health for all. Her primary areas of interest have been HIV/AIDS and immunizations. She continues to serve as the medical director for the Washoe County Health District's immunization program, and she's active on the Nevada Public Health Foundation Board. She's currently serving on the governor's medical advisory team for COVID-19. And with no further ado, I give you all Dr. Trudy Larson, our keynote speaker today. Dr. Larson, I believe you're muted.
There we go. I finally got it unmuted. Thank you. Well, good afternoon, everybody. It's my pleasure to welcome you here to and we're going to start off with a bit of science, because I think much of what is misunderstood about influenza is scientific, and it is not unlogical, and I think it makes a lot of sense, and I hope to help you understand how this virus works, how our vaccine works, how we do in terms of our vaccination, and when we don't vaccinate well, what happens with impact to our country, both in terms of disease, deaths, but also significant financial concerns. So with that, let's start with the first slide. So influenza is a respiratory virus. You've heard a lot about respiratory viruses over the last 9 months because COVID-19 is also a respiratory virus. Influenza is a different one. And influenza is a submicroscopic particle that infects cells. And influenza likes to infect cells that are part of the respiratory tract. And so it seeks to enter cells in the nose, throat, down the trachea, into the lungs, and cause damage when it affects those cells. And that's what actually produces the symptoms. Next slide. So let me talk a little about this virus because it's very problematic. And it's problematic because it changes every year through mutations. And sometimes these are small mutations, sometimes they're big. And the major proteins are N and H. So H is a hemagglutinin type, and N is a neuraminidase type protein. And these proteins are really important in terms of being markers for antibodies. And so when these proteins change, our body that has been exposed to influenza viruses every year doesn't recognize this changed virus particle. And so it evades our antibodies. It evades our immune system. And so that requires that we have to have a new vaccine every single year. And so you can't have a one and done yet for influenza vaccination. It really requires annual vaccinations to be able to address these changes in the virus. I think you all remember 2009 when we had the onset of the H1N1 major mutation. You know, that's the same virus type actually that caused 40 million deaths in 1918. And so there was a lot of concern about what this virus might do to our current population who had not seen this virus before. It was a very rapid scale up. I'm sure that's the only time in my entire career I've ever seen people line up to get vaccinations. But I think it was well worth the effort, recognizing that this virus can cause substantial illness and death. Next slide. So let's talk about transmission. If you remember nothing else about this talk, I want you to remember this slide. Because transmission of viruses occurs through this airborne mass of mucus particles, all carrying infectious virus. This happens to be a photograph of a sneeze, but it can be through coughing, laughing, speaking loudly, singing. It has these bursts of particles that come out in the air. And you can imagine if you were within 3 feet of that person, you would get a lot of particles from this sneeze. And they're all carrying infectious particles when people are infected with influenza. So that it's very important to understand the ability to stop transmission here. We've been practicing it for the last 6 months. Masking stops this cloud of mucus from coming out and provides a way to help in the transmission. So you know, it's effective for influenza as well. Australia had the smallest number of influenza cases that they've had for years because they were utilizing masks and distancing for COVID. So they're very similar in terms of halting transmission. The lucky thing for us, however, is that we have influenza vaccinations that can prevent people from getting exposed, either through this cloud of infectious virus, or you might imagine that these particles might fall down on surfaces and people's hands will get on those surfaces and could rub their eye, rub their nose, and be another way of introducing virus into their system. So don't forget this cloud and that this has got virus in it. So what happens to the person who's infected? Next slide, please. First of all, this is a fast infection. You've all learned we have 2 weeks for COVID. Well, it's about 2 days from exposure for influenza. So what happens is the virus gets inhaled in, it gets into the nose, in the respiratory area, begins causing infection. And in fact, it starts multiplying and being present 24 hours before a person might get symptoms. So during that period of time, a person who's infected with no symptoms, so we might call it pre-symptomatic, can actually infect others. And this is true of most viruses, where people are infected and infectious before they ever have any clinical signs. This is one of those conditions where vaccines can be particularly important in terms of preventing this. And people who get influenza are infectious for 5 to 7 days after the start of their symptoms. So it's a long period of infectiousness. And I always tell people to consider during the winter what they hear when they enter elevators. Lots of coughs, lots of sneezes. We get worried about that closeness. So again, because of the ability to easily have this virus transmitted, it's a perfect place for vaccination. So what happens once you get exposed? It's now 2 days later. You get an abrupt onset of fever, high fever. By the way, this is not a mild fever. High fever, muscle aches, sore throat, non-productive cough, headache. This is very similar to other conditions we've been dealing with. But in this particular case, it feels like you've been hit by a truck. Those muscle aches can be really significant. And so this condition is truly what flu is about. It does not include nausea, vomiting, or diarrhea. Those symptoms are caused by other viruses. So it's this classic fever, muscle aches, productive cough, you want to go to bed kind of feeling. These infections are much more severe in those under 5 years of age and those over 65 years of age. And that's principally because those age groups have immunity that is not as robust, it's not as active as those in the middle years. And so this is the group where we see hospitalizations primarily, and where there are more deaths. And for influenza, the average is about 0.5 to 1 death per 1,000 cases. So a fairly substantial death rate. Again, it's primarily seen in these two groups, those under 5 years, those over 65 years. And the reason they often die is not because of what influenza does to the lung, but it allows for complications to occur. And the big one is bacterial pneumonias. And so it's classically bacterial pneumonias that will kill people, even with antibiotics. But it is the influenza that they get that predisposes that. There's other bacterial secondary infections that occur. I have been getting immunized every year for the last 30 years. And my reason for doing that is I got influenza. And I got a secondary complication of bacterial sinusitis. And I was out of work for 3 weeks. I am humbled about this virus. And so I get vaccinated every single year because I do not want to go through that again. So I've not only seen this, but you can see that in the statistics that we have as well in terms of outcomes from this virus. Next slide. So what does this look like nationally? So this is from last year's influenza season for the entire United States. And I want to bring your attention to some figures. First of all, on the left side, you can see the age groups. And then the next column is symptomatic illness, which means they have what we call influenza-like illness. And so they have this fever and the cough. And you can see the number of cases that are reported in the United States. And by all ages, it was almost 40 million cases were identified last year in the United States. If you go to the next column over, medical visits, you can see that those almost 40 million cases resulted in 17.5 million medical visits. People who felt ill enough that they went in to see their doctors, or they went to a clinic or an urgent care somewhere, but they needed to see a provider. The next column over is those who actually had to be hospitalized because their illness was so severe. And again, you can see a total of over 400,000 hospitalizations for influenza last year. But I think if you look over the age groups, you begin to see where as you age, the likelihood of hospitalization gets higher and higher, and the highest group by far with the lowest number of reported symptoms is that group over 65. So of the 400,000 cases, 177,000 or so were in that age group. And then if you go to the next column over, you can see deaths. And clearly the group highest, most at risk for deaths are those over 65. But you can see how there's a progression through the ages. As you get older, there's more risk, particularly for those who have underlying conditions like diabetes, like high blood pressure, like cardiovascular disease. They have worse outcomes with influenza than those who are younger and who are healthier. So this is a substantial burden every single year in the United States. It varies up and down, but this is fairly consistent year over year. Next slide. Thank you. So how are we doing this year in Nevada? So what is reportable to the health departments is what I termed influenza-like illness. And it is defined as a fever over 100 degrees Fahrenheit and a cough or sore throat where there's no other cause. And particularly this year, we have to make sure they don't have COVID-19 because they're very similar symptoms. So these conditions are reportable both in the north, particularly in Washoe County. We have a very active reporting system, and also in Clark County through the Southern Nevada Health District. So they get reports of influenza-like illness. In Washoe County, I brought up the figures as of the 7th of November of that week. They saw there are providers who report they had 107 patients who had this influenza-like illness. Of those seen, it made 1.8%. That is pretty low. And so we really haven't had any significant identification of disease yet this year. And of those who were identified with influenza-like illness, it was highest in the youngest category and lowest among a pretty healthy young adult adolescent group. And as of that week, there were no influenza-associated hospitalizations or deaths. However, this week, there were 2 cases hospitalized. Both of them did not require ICU care, but those are the first 2 hospitalizations that had culture-confirmed influenza in Washoe County. And then in Southern Nevada, they had the same kind of reporting. However, as of the last end date that I saw, there were no hospitalized cases or deaths due to influenza in Clark County. Now, you might wonder why, because typically by this time of year, we have a fairly high number of cases already reported. But as I told you, mitigation strategies for influenza are exactly the same as they are for COVID-19. So this may be a substantial impact of our current procedures to wear masks. And this may be having an impact on influenza. I sure hope so. Next slide. So who should be vaccinated? Who should be vaccinated? Well, the current recommendations are everybody who is over 6 months of age should get an influenza vaccination every year. So this is a pretty universal requirement or recommendation. And the reason it's at 6 months is because we do not have any vaccines that have been tested in babies less than 6 months of age, so we do not know that they're effective. In all other age categories, all the studies have been completed to identify that the vaccines are effective in the age groups that are encompassed for everybody over 6 months of age. There's a lot of different kinds of vaccine, many different manufacturers, but there's really no preference given except in a few circumstances. So those over 65 have recommendations to get the high dose version of influenza vaccination. That's to help stimulate the immune system to make more antibodies so that they're better protected. Each of the vaccines that are currently licensed for use have either 3 or 4 strains of virus, and that is done to try to cover everything that might be circulating in a single year. And you'll hear a lot more about virus strains with our next talk. We do have, in addition to the injections, all of these are injectable, there is also a nasal spray that is approved for use in children over 2 years of age up to the age of 55 years if they have no contraindications. The nasal spray is a live virus vaccine that has been mutated to the point that it doesn't cause any disease. So what it does is it stimulates a good immune response. It's a nasal administration, so children are a lot happier with this one. But it does not cause any of those symptoms. In fact, influenza vaccines are really safe. And they've been shown to be safe in test after test after test after every single time these have been investigated in large numbers of people. These are very, very safe vaccines. Vaccines are held to a very high standard. And so they must be safe. But what do you get with influenza vaccinations? You get a sore arm. I was really happy this year. This year's vaccine did not sting as much as some of them have. And all it was a very mild sore arm. That was it. And that's truly what most people get. There's a lot of misunderstanding about the side effects of influenza vaccine, but these are killed vaccines except for the nasal spray. So you cannot get influenza from the vaccine. They're killed. And most of them have particles of protein in them, parts of virus. So it does not cause any sort of infection at all. And in fact, it just acts in that one time to provide the stimulus for your immune system to respond. And then that vaccine is no longer in your system. And then that antibody is there to help protect you from getting sick. So you cannot get the flu from the vaccine. Now, you may have a little headache. You may have some muscle aches. You may have runny nose from whatever reason, but you cannot get influenza from the vaccines. And I think that's very important. Next slide, please. So how are we doing in Nevada? This is a comparison of Nevada's children age 6 months through 17 years compared to the United States overall percentage compared to where we should be. So our national goal is to have 70% of children vaccinated. And you can see not only do we not make that percentage, but we also don't come up to the United States percentage. So it's somewhere about 50% of our kids. And the reason this is really important is that kids are the transmitters of influenza. And they have had numerous studies showing that if children are really well vaccinated, the influenza in a community goes way, way down. So it's really important to get our kids vaccinated for influenza. Next slide, please. In addition, in these same children, we have disparities about who gets vaccinated in Nevada. And as you can see here, compared to non-Hispanic whites, non-Hispanic Black populations, non-Hispanic multiple race populations, both have a lower level of immunization than non-Hispanic white, non-Hispanic Asian, or Hispanic. And much of this has to do with access and availability. And we're going to learn some more during our panel conversation today about how access gets improved and how we can make this easier for people to get their vaccines. Next slide, please. So the impact of influenza is not only disastrous on health, but also the financial impact is substantial. Every year, 17 million workdays are missed because of influenza. $7 billion is the estimated cost of these 6 days and lost productivity. $10 billion is spent on hospitalizations and medical visits. And children who get influenza miss 3 to 5 days of school. Although this is a weird year, we can't really relate to that very well this year. Certainly for adolescents who get influenza and they miss 3 to 5 days of school, that's a huge impact in their ability to keep up with their studies. So there is a big impact for influenza. Next slide, please. And so this is my summary slide, and these are my key points. First, this virus, influenza, can cause serious disease and deaths, particularly for those less than 5 years of age and those over 65 and those with underlying health conditions. Influenza is costly. It's costly in terms of missed days of work, healthcare, and education. Children are the transmitters of influenza, and so communities do much better when most children are actually vaccinated. These vaccines are safe. They're reasonably effective in reducing disease and death. They're not as effective as we might like. That still remains for our science community to investigate. We can get a better vaccine here, but it does substantially reduce disease and death. And they are very, very safe. And lastly, there are clear disparities in vaccination. And so my challenge to you is, like, we can really do a lot better. Thank you.
Thank you so much, Dr. Larson. So with that being said, I think we have a wonderful foundation to move into our panelist discussion. Today, we have 3 subject matter specialists who are experts in their fields. I ask that as we go through each panelist, you place your flu-specific questions in the chat, specifically in the Q&A section, and then at the end, we'll answer all those questions. So first, we will learn about how vaccines work from our clinician and vaccine specialist, Dr. Mark Riddle. He's the Associate Chief of Staff for Research at the VA Sierra Nevada Healthcare System in Reno, Nevada, as well as a Professor of Internal Medicine and Associate Dean of Clinical Research at the University of Nevada, Reno School of Medicine. Dr. Riddle brings more than 2 decades of combined research, development, public health, academic, and clinical medicine expertise to UNR Med and the VA. Specific areas of expertise include vaccine development, where he spent nearly 2 decades developing vaccines for the U.S. Department of Defense to defeat common deployment-related infections. And today he will speak to the process that is taken each year for vaccine production and the steps taken in order to ensure safety and efficacy.
Thank you. Thank you for the introduction, and thank you for the opportunity to talk to you all. And I look forward to the exchange. Dr. Larson gave an incredible presentation that frames what I'm going to talk about. She touched on many of the things, and we'll go in a little bit deeper to hopefully have us all learn a little bit more about influenza vaccines. So next slide. Having spent 20 years of my career developing vaccines, I appreciate that vaccines are hard to develop, and influenza is no different. And this is a really complicated slide, but I want to kind of just talk you through what all this information means and why it's important. And you'll see this is a graphic that shows right now the 3 different vaccines for influenza that are developed each year. And you see also at the very top is the calendar that starts from February and it ends in, I think, October. The image of I can't see at the very top, but so it takes a good, 9 months to develop this vaccine. And why, as you recall from Dr. Larson, the influenza is pretty sneaky. It changes every single year. It redecorates itself. It goes through a makeover every year, and our immune system it relies on seeing things when things enter our body, and then seeing that exact same thing again. And influenza, given that it does this annual makeover, it's hard for our immune system to remember it. And so every year we need to have the vaccine. And we've been developing vaccines for influenza since 1945, and it's used this old school technology, which is the egg adapted vaccine method. And basically what happens is twice a year, once for the Northern Hemisphere and once for the Southern Hemisphere, the World Health Organization and other public health organizations from around the world and the Centers for Disease Control all get together. They are providing data to a central World Health Organization body that looks at what strains are circulating and estimates and calculates, not perfectly obviously, but what they think 9 months from now the circulating strains will be. So as you can see, it's a little bit of a guessing game because you have to predict what's going to be circulating 9 months out. And amazingly, this World Health Organization, these global health experts do pretty well. They 60% of the time, get it right, and that's pretty good. And as Dr. Larson said, there's 3 strains, and usually one of those that they predicted will always be there. Usually 2 of them, but we don't get it 100% every time, and so that's one of the things to understand. But and then once so in order to make the vaccine through these processes, it takes 9 months to infect the eggs. For example, for the top line, have the virus grow up in eggs, and then you basically crack the eggs open. You harvest the virus from that. You inactivate it so that it doesn't cause any infection. Purify it, and then put it in vials or in syringes or however it needs to be delivered, and ship it, and then vaccinate people. And despite 45 years of work, it's been challenging to shorten that timeline. This is the way the vaccine works, and this is the methods we have. And there has been multiple efforts to create a vaccine that is just once a year, and we're getting closer, but we're not quite there yet. There's 2 other ways vaccines are made. One is by taking cells that the virus can grow up in, but at the same time, instead of having the eggs, get infected and then harvesting from the eggs, it's from these cells, and that still takes a long time. You'll see at the bottom is a newer method that's come out in the past few years, where they insert the genes that make those H proteins and those N proteins that Dr. Larson talked about, and they put them right in bacteria, and then the bacteria make those proteins, and then you purify those proteins and create the vaccines. And that method has increased, as you see, it shortened it from 9 months down to about 6 months, and so that's good. That's been an advance to provide the vaccine earlier and more vaccine. So I know that's a lot to cover, but I think it's helpful to understand how complicated it is, and how we have to be guessing 9 months in advance what's going to be circulating. And that's why sometimes we don't see the vaccine work 100%. It works 50% of the time or 60% of the time. But as you'll see, or as we'll talk about, that's pretty darn good, and that's an important an effectiveness to try to target. So next slide. So the next thing I want to talk about is just how vaccines are developed in general, and then and how we develop vaccines and understand their safety and their effectiveness, and then how once vaccines like influenza are licensed and used, how we continue to really focus on what the safety of these vaccines are. And so this is a slide from our U.S. Food and Drug Administration, which is the government agency that is incredibly dedicated people, knowledgeable people, world's experts in developing vaccines and drugs. And they oversee, you know, the development of vaccines in our country, and really many around the world have adopted the practices of our agency. So the vaccine goes in 4 phases. One is a preclinical phase, and I don't have any detail there, but what's happening in a preclinical phase is that you're trying to just understand how a given infection causes an illness, and then you're trying to figure out, well, what is it about that infection? Is it a protein? Is it a surface, you know, decoration, or what is it about that that infection or that bug or that virus that causes the infection? And then how do people protect themselves from an immune response standpoint to protect from getting infected? And this is called the preclinical work, and it's often done in both humans, where you're studying the natural infection. So, for example, with the COVID disease right now, there's a lot of work understanding how the virus causes illness and that. But it's also done in animals as well, where if there's an animal model that mimics influenza, so like pigs can get influenza and birds can get influenza, and so research is done to understand how infections work. But at some point, you get to the idea where, okay, well, we know how this bug infects people, and we know it's this one protein on its surface, and if we can block that, then that bug is not going to get inside us and make us sick. And at that point, you create that vaccine, that protein, and you do a very small phase 1 study, like 10 to 30 people, and you go very slow with very low doses, one at a time. Again, this is after there's been a lot of studies in animals and other ways to measure whether a vaccine is toxic or not. And so phase 1 is an important study, but you proceed only when it's really safe to go. And so those are the phase 1 studies where you're just looking to see if it's safe and if it induces a good immune response. And then you start working into phase 2, where you want to understand safety in a larger number of people. And this could be several hundred to 1,000 subjects. And you've picked the dose that you think is going to work best. And you vaccinate larger numbers, and you look both for the immune response, as well as to make sure that the vaccine's not causing any adverse effects that are serious. And then once it passes that phase, then it goes into phase 3, where there's several thousand subjects. And for example, right now for the COVID vaccines, these phase 3 studies are in 45,000 to 60,000 people that they're doing these studies. So very large studies, where you're primarily at this point wanting to see if the vaccine works to prevent the infection, but you're also looking at those rare side effects, because when you start giving a vaccine to thousands of people, you can detect these rare side effects and really understand the vaccine safety even further. And all of these studies are closely monitored, not only by the principal investigators that are doing the studies and their teams, but also independent data safety monitoring boards that are independent from the study, independent from the people that are developing it, and the FDA, who are completely independent. They're looking at the data each step of the way. So that's, in a nutshell, that's what it takes. And that can take 10 to 12 years to develop a vaccine, which is remarkable. In the future, we can talk about how we've done it more quickly with COVID vaccine. So next, click the button. Once all those studies are done, then the vaccine goes through licensure. And that's about a 2-year process, where the FDA really looks at every single line of data and makes sure that that there's no safety issues and that it's effective. And then then it can be sold and utilized. At this point with influenza vaccines, because we've been using these for 45 years, every year we don't need to go through this process again. There's so much knowledge about what are the important antigens, how these antigens look, how the immune responses antigens behave, that we don't need to do the phase 1 through phase 3 every year for an influenza vaccine. It is done in part when there's a pandemic or a brand new strain that's never been seen, then you will see this development. But for current annual vaccines, that's not required. But that's not to say that we stop looking at the safety of these vaccines. So next slide, or next click. So post-licensure, so that means after a vaccine's been approved and it's in use, and this goes for every vaccine, not just influenza vaccine, there are a number of systems that are run by the Centers for Disease Control, but with collaboration with the FDA and other health organizations and academic institutions, where anybody who thinks they have an adverse event to a vaccine can report vaccine adverse events to this vaccine adverse event reporting system. In fact, if a company learns that somebody had an adverse event, they have a duty to report, as well as healthcare providers can report this. So this is one system where it's up to people, but the people can they look at these reports, they try to look for trends to understand timing of things, and it's a good system to pick up potential problems with vaccines. The next one is a little bit more designed to really accurately look at the safety of vaccines, and that's the Vaccine Safety Data Link. And that's a collaboration between the CDC and big managed care organizations like Kaiser Permanente and others, where people are sharing data about when people get a vaccine, including the influenza vaccine, and looking at their electronic records to see if they develop any sort of adverse event that's not related to the infection. And this could be headaches, or one of the things that came out was with one of the vaccines was in a certain age group there was narcolepsy associated with the vaccine, and they were really able to quickly identify this and understand the risk of it and which age group were experiencing that, and then quickly change recommendations as needed. And then the third one is this clinical immunization safety assessment network. And say there's a new adverse event that we hadn't seen before, there's a network of scientists who study how this adverse event is happening by doing studies, blood tests and other studies to really understand what's causing this and learning, and all the time there's a constant vigilance and updates in terms of if a vaccine should be recommended to a certain group or not. And so this is a very active effort to make sure vaccines are safe. And this is for influenza as well as all vaccines. Next slide. So switching gear then about vaccines, and I wanted to touch on the point of effectiveness. And, if you ask 10 people what do they think it means by a vaccine being effective, you may get 10 different answers, and that's because there are a lot of different ways to look at effectiveness. This is a graphic that I hope that kind of explains that and describes multiple ways that a vaccine can work, and the influenza vaccine works in all of these ways, but you could have a vaccine that works so well that when you got that cloud of respiratory droplets that Dr. Larson so nicely showed, your body completely blocks it and doesn't even let that enter your body. So that's the ideal. It's hard to make a vaccine like that, but that's our goal. Sometimes you get good immune responses and you can get that way. But the other things that are important are reducing disease severity. So maybe you still get influenza, but it's not going to put you in the hospital, and it's not going to lead to that bacterial superinfection and the really bad outcomes. It's just you're going to get sick, but you're going to make it through. And that's great too, because while we don't want anybody to get any sickness at all, having a vaccine that prevents you from dying or from being severely hospitalized is great. And then we get into the other really important things about vaccine effectiveness, and that is the ability of a vaccine to prevent you, who might be sick or carrying the bug, from spreading it to others. And as Dr. Larson mentioned, children are known to be an important spreader of influenza, and so vaccinating, when you have high rates of vaccination in children, it reduces the vaccine in the community. But there's also studies that show that in hospital settings, the higher rates of healthcare workers in the hospitals that have vaccination, the lower rates of death in the patients in those hospitals. And so this really argues and supports the notion that it's important to protect yourself, but taking a vaccine could also protect others. And so you're not only are you doing it for yourself, but you're doing it for others, and that's important. And so those I think are hopefully help you understand why influenza vaccine, even though it's not 100% effective every year, how it's important in not only preventing infection of yourself, but others, and how every year we develop it safely, and sometimes why we don't get the vaccine 100% correct, because it takes a little while and we have to predict what's going around. So I'll stop there. Thank you.
Thank you so much, Dr. Riddle. I believe that has gave us some insight about vaccine production, and we will move to how people who become infected with the flu virus can experience unfortunate emergency outcomes, as well as factors that influence it. And that brings me to our next panelist, Dr. Bayo Curry-Winchell, our family medicine physician and urgent care specialist. She obtained her medical degree at Ross University and completed her residency at the University of Nevada, Reno in family medicine. In addition to being a practicing physician, Dr. Curry-Winchell is the medical director of St. Mary's Urgent Care Clinics. And today she will talk about how the flu can present as an emergency and how healthcare disparities can play a crucial role in that process. Dr. Curry-Winchell will focus on how to raise awareness and promote flu vaccine compliance within an emergency setting. So I will hand it over to you, Dr. Winchell.
Thank you very much for the introduction, and thank you for allowing me to participate in this. So I'm very thankful. So first, what I'd like to start off with is I want to provide an example of what I see in the urgent care and in respect to patients who present with flu-like symptoms. So as Dr. Larson mentioned, as well as Dr. Riddle, patients will report a history of fever, fatigue, cough, and body aches. And so when they present in the urgent care, we will collect samples to test for the flu, as well as, in this time and age, COVID, and additional tests as well, depending upon the presentation. So the severity of the symptoms will determine if that patient will need to be sent to the ER. And so now I'm really able to provide some information based on when the symptoms that all the panelists have discussed, when it rises to a higher level, what happens from there. So when patients present with flu-like symptoms and they have a high fever, higher than what Dr. Larson mentioned, higher than 100, and it's not controlled with Tylenol or Motrin, if they present with a decreased appetite, which can actually lead to dehydration, which can lead to the body's inability to maintain organ function, or if they present with severe fatigue or generalized weakness, or everything that I just mentioned, all of those things really elevate the need for a higher level of care. And so by explaining those things, I'm hoping that will really inspire the participants on this webinar to really reach out and spread the word on how important it is to get the flu vaccine. So in that, I also want to talk about the barriers and disparities that we see with the flu vaccine. As Dr. Larson mentioned, there is a huge disparity amongst communities of color to actually access a vaccine. And so the question is, why is this happening? And it starts with, limited access. And that comes down to primary care access, pharmacies, which we know often are able to provide that, as well as limited linguistically and culturally preventative health information. So those things really impact access, as well as lack of insurance and mistrust in the government are some of the reasons why the disparities exist. And so when you have everything that I mentioned in place, that will lead to a longer period of time of the symptoms that I mentioned in getting care. And when that happens, that's when you have to, unfortunately, sometimes end up in the ER. And so again, that's why it's so important that we really look at the foundation on how we can improve the barriers and disparities in hopes of actually improving overall care. So I wanted to provide some ideas and suggestions and things that I think in our community we're really looking at in order to hopefully decrease that disparity. So one thing I wanted to mention, and Dr. Larson mentioned this as well, is when patients present with flu-like symptoms and unfortunately they have to be hospitalized, I feel that's a really good time to really educate, even if it's just a couple of minutes, and provide that information that next year I really want you to think about getting vaccinated in hopes that even if you do get the flu, it will be less severe. You won't end up in the ER. All of those things can be really impactful when you have that patient in front of you. The other thing we need to think of on a community standpoint is increase clinics, increase pharmacies in communities of color, and really look at our area where we have access and really think to ourselves, how can we improve? Because currently, we are still very limited in just simple areas of being able to get vaccinated, especially like pods and pharmacies and so forth. The other thing that's really special and close to my heart is increased representation within the healthcare. And I think that really matters. If you can have a provider who looks like you and then be able to actually provide that information, it can really be impactful, where that patient may actually say, you know what, I think I'm going to go ahead and get the flu vaccine, just because that person was able to identify. So I think those things are key, as well as improving health literacy in order to provide education on a larger scale, and producing events like today I want to really mention, which allow for the opportunity for dialogue and discussion about the flu vaccine and why it's important. So those are some of the things that I feel really can make a change, as well as decreasing disparities. Next slide, please. So we've seen a lot of graphs today, and this one as well really highlights the disparities that we have amongst communities of color. And so I really encourage everybody on the panel to think about the suggestions that I mentioned and go out and see what you can do in your community. And even if it's just spreading the word where, I learned something about the flu vaccine, and spreading that information, that can really make a difference, as well as, reaching out to people in the government and saying, we really need in this community, we need to have more pharmacies, we need to have more primary care clinics. All of those little things add up to big changes, which then will change the numbers that you see in front of you in those in respect to disparities. So I hope that was helpful, and I'll let the next speaker speak. Thank you.
Thank you so much, Dr. Curry-Winchell. I think those are wonderful steps that can definitely improve the long-term success of those patients. And our next panelists will discuss how we can avoid going to the ER related to the flu. Dr. Andy Pasternak is our family medicine physician and vaccine advocate. He graduated from the University of Michigan Interflex program, and he completed his family medicine residency at the University of Wisconsin-Madison. After residency, he completed a 2-year primary care research fellowship at the University of Wisconsin-Madison and received his MS degree in chronic disease epidemiology. He's currently the president-elect for Nevada State's Medical Association. And today he will give us insight into how having a consistent relationship with your primary care physician can increase flu vaccine compliance. Additionally, he will share how this relationship can help ease hesitancy related to receiving the vaccine, address barriers that prevent vaccination, and the effects of not being vaccinated for flu or other disease and illnesses such as COVID-19. And I will hand it over to you, Dr.
Thanks for having me today. This is a really impressive session. I always love these because I learn from all these sessions. Every time I hear something with vaccines and hearing the previous speakers all talk, I picked up some issues or some really good teaching points from all of them. So it's going to be tough to follow them. But I kind of want to start out first with my background. So I'm a family practice physician. I've been in Reno for 22 years, and I've always advocated for vaccines. I understand the importance of vaccines, but one of the things that really brought it home for me was actually, I'm going to tell a story about a friend of mine from medical school and his wife. My friend, he was the guy in medical. I think we all had someone like this in medical school. This was the guy who was not only learning the material, but as a medical student was actually writing textbooks. Absolutely brilliant guy. And he ended up getting married to another physician. Again, she was incredibly brilliant, pediatric surgeon, did research on all sorts of pediatric surgery issues, but then also did a lot of ethics research. So not only, just like I said, absolutely brilliant woman. In 2016, she unfortunately came down with a form of leukemia, and it was late December of 2016. And part of her treatment, she had to go through chemotherapy, and one of the things she ended up having to get is basically a bone marrow transplant or a stem cell transplant. She got through all that stuff. She was doing great, back to work, helping people, going back and doing the things that she loves. And then late in 2000, or basically less than a year from then, she ended up getting influenza. And the influenza, as Dr. Larson talked about, the influenza is tough. She ended up getting a bacterial infection on top of the influenza, and unfortunately, she passed away. It really brought home to me, here's a person that we put all this effort, all this energy. She got the best treatment. They probably spent hundreds of thousands of dollars on her treatment, and we worked so hard. Her physicians worked so hard to get her better. And really, at the time, she couldn't get a flu shot. Obviously, her whole family did, but it could have been someone that she was exposed to who didn't get a flu shot that cost $20 or $25. That could have been the difference between her getting the flu and not getting the flu. So it really, really brought home to me how important it is not just to get a flu shot for yourself, but it's also really important to get a flu shot if you're around other people who have chronic medical illnesses. I think one of the things that COVID is really pointing out to us in our community, there's a lot of data that people with comorbidities are having worse outcomes with COVID. That's also true with influenza. And I think COVID's really pointing out we're surrounded by people who have chronic medical issues. And so that it's absolutely critical to get vaccinated for things like the flu. So those are some of the things. As a primary care physician, we have patients come in, and usually starting in September, even in August, we get people asking us, should I get my flu shot? And we start asking patients, we start asking patients, have you gotten your flu shot this year? And we really advocate for it for that reason. We know it's going to help the person, but we can also, if we vaccinate enough people, we can help to keep the flu rates down in our community, which is going to help the overall health of our community. I think we've kind of heard some of the barriers. We get people saying, well, when I get the flu, I've gotten a flu shot before and I got the flu for my flu shot. So we usually have, and Dr. Larson sort of talked about that, sort of making that distinction between, what's a localized reaction or what's your immune system revving up for this, versus actually getting the flu from this. You know, and we also hear things like, you know, the vaccine's not that effective. It's only 50%. Why would I get a shot? So again, we try to have some of those discussions with people. A couple of resources that I do try to get out to people, you know, are we do. So there's something called WebIZ, and what WebIZ is it's a state program that's basically a good way for us to monitor what vaccinations people need. And I can tell you, doing vaccinations in any office, it's actually a lot of work. When we get vaccines that come in, they have to be stored at particular temperatures. They have to be inventoried. Some of the vaccines have to be stored at freezing. Some of them have to be stored at, you know, 30 degrees. So there's a lot of work that goes into it. And so one of the things that helps to kind of streamline some of this work is the state has a program called WebIZ. What WebIZ does is it's a way for all the pharmacies, clinics, hospitals to report which vaccines they've given to which people. And it's a nice way for you that we can use it. And so this morning I had a 16-year-old boy come in, and it's his first visit with me. We didn't really, some of his records, we had a few of his records, but not all of them. But we could get on WebIZ and run a report, and it was basically like, oh, you're 16, you're due for your second meningitis shot. So it's a really, really powerful tool. One of the things that I'm trying to get across to people is people can access their own records on WebIZ. So one of the issues I know that we have in Nevada is we do have a shortage of primary care physicians, family physicians, pediatricians. So a lot of times people don't have that primary care home. But I would encourage people, you can get on WebIZ, you get on the internet, you can, and I can maybe try to send the password or the link to people afterwards, or maybe in the discussion I can put it on there. But you can go on there, you type in your personal information, it sort of verifies that that's who you are, and you can run your own report. It'll say, hey, you're due for a flu shot, you're due for a tetanus shot, you're, you know, over 65, maybe you need a pneumonia shot. So those are some of the tools that we're trying to get our patients to use so they can kind of stay up in their health. And I think it's important for people in the community to do that as well. The other really good resource that I try to get people to know about is Immunize Nevada. And Immunize Nevada is a nonprofit in our state that does a lot to promote vaccinations within our community and within our state. And it's my favorite resource for people to go to if they have questions and they hear things about, you know, I'm hearing this about the flu vaccine. It's a great place for people to go. It has all the information. It goes through all the vaccines. They have sections for providers, sections for patients. So, you know, a lot of times I tell patients things, I hope they trust me. But one of the things I try to do is if, you know, they want to get more information, I think it's important for us as primary care physicians to get them accurate information. And places like Immunize Nevada are really good with that. And I see that both Heidi and Brianne are posting some of those things up there for me. So thank you guys for doing that. So yeah, so that's kind of my perspective as a primary care physician. You know, we obviously see a lot of hurdles. You know, I think fortunately this year with COVID in the background, I think the public health messaging on the importance of the flu vaccine we've had good messaging. You know, I would say out of all the years I've been in Reno for 22 years, this is probably the most critical year that we've had for getting people flu vaccine. It's really hard. As some of the other speakers said, it's really hard to tell influenza from COVID. It's fever, it's cough. But if we know people have had a flu vaccine, you know, then that's going to kind of help us think, well, maybe it's more COVID than flu than trying to make some of those decisions. So that's kind of some of the information I had. And I want to make sure that we leave plenty of time for questions here. So I'll kind of sum up with that.
Thank you so much, Dr. Pasternak, and thank you all for your insight and education. So as a reminder to all the participants, this is the first of a two-part series, and the second part will be focused on COVID, so hold those questions for that session. But if you haven't had a chance, please go ahead and put your questions in the Q&A section, and we're gonna go ahead and move into our Q&A session. It'll be facilitated by myself and Alexandria O'Neill, and I know she has some questions loaded up for everyone.
I am Alexandra Neal. I'm going to ask a few questions that have been placed in the Q&A box, and I just want to really emphasize what Paulina has already said, which is if you have any questions, please place them in the question and answer box. We will answer them live. Any questions that for some reason we do not get to will be placed in a document that will then share or be available with the answers along with the recording from the Office of Minority Health and Equity. So my first question, which Dr. Pasternak and Dr. Larson have already kind of addressed, but I guess I would just like a really clear, straightforward answer from either one of you from our audience. It says, why when I have received the vaccination, I am immediately sick upon inoculation and have later gotten the flu, versus when I have not gotten the flu vaccination, have likewise not had the flu. So why is it that when they got the shot, they were sick and later on they had the flu, and versus when they did not get a vaccination, they were fine? Either Dr. Pasternak or Dr. Larson.
I'd like to start with that one. And all I can say is if you haven't gotten your vaccine and you don't get the flu, that's a lucky year. It really doesn't have anything about not getting the vaccine as being protective. You're lucky, and that's nice. But what I want to really, when you get this vaccine, as I said, it's killed. There's no live virus in it. In fact, most of the time there's just parts of a virus in there. But when you get the injection, your immune system starts responding. And it's your immune system response that causes the symptoms. And even when you get influenza, the symptoms are usually because of the immune response. So you might say, okay, I got the shot, and that evening I started, feeling sort of bad, and my arm really hurt, and the whole next day I didn't feel good. Well, that's because your body is appropriately making immune responses that will keep you from getting a bad case of influenza. As Dr. Riddle mentioned, we don't always have a perfect matchup with the vaccine that's in the shot and the influenza that's in the shot and the influenza that's circulating in the population because of that 9 months. And there may have been mutations happening during that period of time, but it still boosts immunity sufficiently to reduce the risk of a bad outcome. And so that's why even in a year where there's a major mismatch, getting the flu vaccine that year provides antibody in your body that will help protect you in following years and will help mediate severe disease. So here's what I wish for. I wish for a vaccine that actually will address every single influenza virus. And you may read about this. It's called a universal influenza vaccine. It has not been possible to create that vaccine yet, but that's really where we would expect to see levels like 90 to 95% effectiveness when we have a vaccine that is able to attack every influenza. Until we get there, these yearly influenza vaccinations will prevent serious disease and reduce risks for hospitalization. And I think that's really, really important.
Yeah, I'll just sort of echo that. I think, two comments I have with that is, sometimes when people say they have, I get a lot of patients who come into my office, and I think Dr. Curry Winchell probably has the same in urgent care. They come in there like, I have the flu. And we sort of use the flu as kind of this generic term. But when we're, as physicians, when we're talking about the flu, we're really talking about influenza. So sometimes I do think there is some confusion. the flu shot helps you with influenza. There are a lot of other viruses, adenoviruses, rhinoviruses, that can cause colds. And the flu shot isn't going to necessarily, it's not going to block you from getting a cold. But it will help with influenza. And to echo what Dr. Larson just said, when we've had some really bad flu years, I will have people come in, they have a cough, they have a fever, we'll test them, and they turn, we can do a quick little test in our office to swab them and see if they're positive for influenza. And we've had a couple years in particular where people will come in and they're like, yeah, I have a little runny nose. We test them, they're positive for influenza, and they're like, oh man, I'm really sick. And I'm like, well, you're not as sick as the person who I just saw who has a fever of 103. And, we had to send them to the hospital because they need oxygen. So I think that there is also something that the concept of, the flu shot may, hopefully it's going to help to prevent influenza altogether. But really, in a lot of years, we do see where it really helps to mitigate the severity of the disease.
I'd like to jump in on that too. So exactly what Dr. Larson and Dr. Pasternak mentioned. I had last year an 80-year-old who had flu-like symptoms, but she had received her flu shot. And I think if she wouldn't have, I probably would have had to send her to the ER. Inversely, I had a 40-year-old who did have one underlying health condition who was hypoxic, meaning not able to get enough oxygen, and I had to send him to the ER. And he was hospitalized for 1 week. And so, again, it really can make a difference. So if you do get the flu shot, the symptoms are less severe. So I echo what everybody else mentioned.
Thank you, guys. Our next question is going to be for Dr. Riddle. Is the push for vaccination compliance medically or politically driven?
Let me repeat the question. Is the push for vaccine compliance medically or politically, what was the last part?
Driven or motivated?
Oh, that's a great question. I think when you think about medicine and politics, and then you're getting into public health, because the government is one of the things the government does is try to make sure that the roads are safe, that the food that we eat is safe, the water that we drink is safe, and a whole host of safety issues and important things for our population to remain healthy. And so I think if you're talking, if I could phrase the politics in terms of government, I think we are the everybody from the local to the state to the national level want citizens of our country to be in good health and to stay in good health. So I think it's motivated by wanting people in our communities to be well. It's also from a medical standpoint, I would say yes too, because we as clinicians, as nurses, as PAs, as doctors, as pharmacists, we all want the patients that we take care of to be well as well. And so we believe strongly in the value of vaccines and the importance of vaccines for maintaining the health of our patients. And so I would say yes. If I framed those two particular constructs correctly. Absolutely,
thank you. I feel
Can I jump in on what just one sort of topic on that one? So another sort of when Dr. Riddle was one of the things I was talking about is one of the things I've sometimes seen is, well, doctors are receiving financial incentives to give vaccines, and whether or not it's usually not coming from the government, but some of the healthcare plans are, they'll have if you can make sure that your children's vaccine, the immunization rates are above 90 or 95%. Some of the insurance plans now are saying, oh, we're going to give that doctor more money for higher vaccine rates. Well, I try to, sometimes that gets twisted the wrong way, but I try to tell people the reason why the insurance companies and the government in part want you to get these vaccinations is that's how it ends up being less expensive care for people. You know, it's a way to prevent treating diseases, and treating viruses is really, really hard to do. I mean, some of these viruses that have been around, we still don't have fantastic ways to treat them. You're treating the symptoms, but we don't have specific medications that will kill off that virus like they do with bacteria. So really, you know, I don't want to say it ends up being cheaper, but you know, we all know it's much easier to keep someone healthy than it is to take care of a sick person. So that's why those incentives are there, because you know, the more we can keep people healthy, it helps everybody.
That's very true. I didn't think about it from that point. Because when you had first started, I was like, wow, I didn't know they pay, like incentivize doctors to do that. But that makes sense. Our next question is, has there been any problems with higher doses for senior citizens? And that question will be for Dr. Larson.
So I'd be curious to know sort of what the issue was there. So there are 2 manufacturers that have high dose influenza vaccines, and I think they've been in short supply this year. So they're not as readily available as they might have been in the past. This happens periodically. As you noted in Dr. Riddle's very complicated slides, there are a lot of places in that process where there can be issues with supplies. For example, eggs. What if it was a year where they had a real difficult time getting the right eggs? That's just an example where there might not be as much vaccine available as we would like. But the high dose is recommended. It's not always available. Like, I'm over that age group, and I could not get my high dose this year either. So I think it's a little bit of a supply issue this year for the high dose vaccines for influenza. Get the regular one. It will still induce immunity, and especially if you're a pretty healthy person over 65, then you have a very good chance of having a good immune response to that dose, if that's what the question is.
I believe it's asking side effects.
No, there aren't. It's okay. So if you think of side effects as being due to the immune response, so the bigger your response, the more side effects you have, but it means you're doing a better job with making your immune system work to protect you. Then if your immune system is not as good, which classically happens as you get older, then you're not going to have the same immune response. So you may not have the same side effects. It's a very interesting, because it is about the immune response.
I'd like to just piggy on back on that. Dr. Larson, you make a really important point that, you know, vaccines they're not innocuous. You know, they're very safe, but they do cause a reaction, and that's important, because that means that your immune response is seeing what it's supposed to see and developing this important antibody response. But you're kind of trading off for a little bit of a sore arm and maybe feeling, you know, a little tired and a headache. But that's much better than having the disease and potentially having really severe outcomes. And so it's a trade-off. And so vaccines are not completely innocuous, but they are safe. And they do create a little bit of a reaction, and you got to expect that. But it's worth it.
Absolutely. So our next question is, what are the signs and symptoms that signify I might need to go to urgent care versus a doctor's appointment? And this is for Dr. Curry-Winchell.
Yes, thank you. So the signs and symptoms, just in general, to seek medical attention, like I mentioned, if you have fever, cough, just generalized fatigue in general, you should really reach out. And there's so many different avenues now for medicine, which is really helpful. And by that, I mean telemedicine or the traditional, you know, walking in. Of course, right now with everything happening, we discourage that if possible, you know, calling and making an appointment. But the signs and symptoms where you really need to go to the emergency room are, you know, the fever that's not controlled, just a general malaise where you are not not able to really do anything at your baseline. And those are signs that you should go. And I always say, if you have a friend, a partner, a family member, they know you best. And if they can tell that you're not able to articulate like you normally do, give good eye contact, or you're not keeping food and drinks down, that is a sign that you really should seek a higher level of care. Now, if the nearest location is an urgent care, go there first, because at least then they can stabilize and then call, RIMSA, or just find a way to transport you to the ER.
Thank you so much. Okay, and then Alexandria has a question.
Yes, there was a question sent to me via privately through the chat, so I wanted to make sure that it was asked, and it's regarding how can we trust what goes into the vaccines when you take into account the history of medical research and distrust. For example, the Tuskegee experiment, or what happened with Henrietta Lacks, and different occurrences like that that has happened throughout history. How would you say we can trust what goes into these vaccines?
I would love to get each of you guys' input.
That is a great question. It's something that I think we have to have ongoing discussion on how we can improve it. So the Tuskegee experiment, that's a huge example of the level of mistrust that occurred in our community. And when I did a talk previously, I actually had a really powerful picture that stated, it said, health department, please come and get treated. So when you have those types of examples affiliated with the government, and then unfortunate outcomes that actually had, obviously there's fabrication and so forth, it's really hard to make a change and make a community feel like this is something that they should trust. So the big thing for me is health literacy. I think educate yourself, because as much as you can learn, and granted, I know there's different areas, it's hard to kind of be at a nurse's level or a physician, but there are things that you can learn about when it comes to vaccinations, because I feel if you can educate yourself and understand what's being offered, I think that's very powerful. And that's where it starts, with education, as well as when I mentioned representation, having someone who is in that same group. As I'm an African American and I have that same history. So reaching out to those healthcare providers, if that's where your comfort lies, and having a discussion with them about why they think it's best. So those are some of the starting points. And if there's other suggestions, this is something that I'm very passionate about. I welcome it. And I think we just have to have ongoing discussions and with different groups, because everybody's different and we need to find out how we can make change.
So I'd also like to comment that that the horror that was identified with this totally unethical research endeavors is now being taught over and over again in our schools. And in our particular school, we have a whole course on the ethics of health. And this is discussed and talked about as being a terrible episode, and one that we take personally and requires transparency. So when people start talking about transparency, I think that's your point about literacy is critical, because you can go in and read anything. The FDA has to put it up. You can read it. It's pretty technical, and I think that's the difficulty. But before, they didn't have any transparency, and so we have to advocate for transparency in all of these interactions. All research projects have to be peer reviewed. They have to be looked at by people who know what they're talking about, and verified and vetted. Vaccines are held to the highest standard in the FDA because we're asking healthy people to take these vaccines in. So they're held to a very high standard, much higher than any medication. And so this is because of these terrible historical episodes that were hugely unethical. And I think this is a part of a commitment of all young physicians now and old physicians too, that we do not allow unethical behavior like this to occur. It needs to be brought to light, and we need to reestablish that trust.
So that leads us into our next question, which I think really will be helpful for all the people that are in attendance. For you, Dr. Riddle, how can we institute a clinic to community approach, one that puts as much emphasis as engaging Black, Indigenous, and people of color in the earliest and riskiest part of vaccine research and development, as we do in enforcing distribution protocol?
That is a great question, and it's been remarkable in the last few years how there has been such a push by both agencies and industry and academia to diversify the populations that are involved at the earliest stages of studies. And why is that important? Well, we all know why that's important, because we're different and our immune responses may be different, and everybody wants to know that the studies that were done in people like me that I can identify with, and it's important for on many levels. And so I would love to engage in additional conversations about that in our community. I will say that, you know, and I know this is for a future talk, but the current study that we're doing here at the VA with a COVID vaccine trial, there is a significant emphasis on diversity, and the companies that are testing the vaccine and the government who is helping to support to advance these things safely and do these great studies so that we can have a vaccine sooner rather than later and save lives, are pushing this a requirement to have representation from many different groups involved in the study. And I think what's needed, kind of pigging back or translating back to that, the question that preceded this, we need to make sure that everybody trusts what we're doing, so that people would be willing to join these studies and be a part of testing these important vaccines and drugs that could save the lives of many. And so I would greatly appreciate further discussion on how to do that and how to provide groups that with that information. In terms of how that's being done right now in these trials, is that the sponsors of the studies that are creating SV are requiring from each of the sites a plan to how are we going to recruit from and enroll and advertise to diverse populations to assure that diversity is included in those subjects that are being so it's real, it's happening, and but I'm very eager to have a conversation with our community to how to do more of that, because I think we are, our community is growing, and we are entering into the ability to do more of these types of studies at all of our institutions, and so a community dialogue is perfect right now to have that. I'll stop.
Thank you so much, Dr. Riddle. And then insight from any of the other panelists on that topic?
This is a long-standing issue. For years, for example, I'm just going to give you an example. In HIV, it took years before there was an approval to use an antiretroviral medication in pregnant women. And so that's another population that does not get included in vaccine trials or other trials. And children are usually delayed as well. So there's a variety of populations that, because like they've just started enrolling children in one of the COVID vaccine trials, we have to have that evidence. We have to have that information before we can broadly use these vaccines, and it has to be in sufficient numbers that we can comfortably and with good confidence say this works, this is safe. And so this is an evolving issue, and I totally agree with Dr. Riddle about this, is the time has come for much more communication with all interested folks to establish a sense of trust and a sense of really wanting to participate and provide answers that allow us to offer medications, vaccines, all of these life-saving interventions to everybody, because it's been tested in everybody. So I think it's just a really important topic.
I think another thing that I really want, I think one of the problems in the past within the medical community is and this happened at so many different levels, is there's always kind of been the top-down approach. And it's been, you know, typically big researchers at big universities and institutions, and when they would do research on various ethnic groups, I mean, there's sort of a derogatory term I call it helicopter research, where these people pop in and they say, oh, we're going to research this population, and they leave. And one of the things that I've been involved with and I try to do promote is there is much more of an idea now of participatory research and getting communities involved. And I think one of the biggest changes that's happening in medicine is I think the medical communities are getting better at listening to patients and listening to patients' concerns. And so we're still not perfect, you know, it's a work in progress, but I think this idea of trust in various communities, we need to, you know, I mean, as a white male, I need to hear from people of color. What, you know, here's what I need from you for us to trust you. And I think it's a dialogue that we need to have. And I think it's something that I really hope that our medical community here in Northern Nevada has open ears and is listening to our communities, because that's the only way that we're going to be able to build that trust.
I agree with that. You know, it starts with, we have a wealth of information as healthcare providers, but if we're not able to deliver it because that patient can't hear us because of that level of mistrust, then we haven't done our job and what we can do. And so breaking down that level of communication so we can really come together, I think is the key.
Absolutely. And with that, that is all the time we have for questions. I want to thank all the panelists, and I believe Ms. Tina will close us out here.
Yes. Thank you so very much. I want to take a moment also and commend those who stuck with this webinar. The participant diversity in the webinar really did my heart good. We had folks representing the NAACP, the Governor's Office for New Americans, the Southern Nevada Health District, a plethora of healthcare professionals, including folks from our neighborhood federally qualified health centers who are just right there in the front lines, several elected officials, including Assemblywoman Monroe Moreno and representatives from Congresswoman Titus's office, and then also, without any discredit, to folks who are just neighborhood friends and family and faith leaders who are just interested in learning more. I just hope that in keeping Dr. Curry Winchell's remarks at heart, that everybody on this call who has their own sphere of influence, that you're going to really embrace the importance of health literacy, and that this is information that's better shared than kept within our own circle. So please, if you have any insight, any inroads, any impact within communities that are different than yours, just please share today's knowledge. And having said that, that lively conversation, we want to take a moment. We have a few people who are still with us, quite a few actually, and we want to take one last poll. If we could put that on the screen. And that question is going to basically read, I don't know how to drag out these things, I'm never good at that. Will you receive this season's flu shot? Yes reflects that you either have taken it or you will. And if no, please indicate if it's because you need more information or you're still skeptical. We need that Jeopardy little clock to ding, 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 ding. Let's see. Almost, I guess. Again, the longest minute in the history of minute watching. Let's see. I have my own thoughts about it. Let's see. Well, there you have it. Of today's callers, of those who remain with us, 64% are saying yes. And of those who are saying no, it's just that skeptical component. It's not even about needing more information. And that information is useful, I'm certain, to those who are subject matter experts on this line and those who are in the trenches trying to bring awareness and replace fear with familiarity when it comes to this topic, and understanding that unfortunately fear does not fix. So we're going to do our best. And I just want to thank again the speakers, Dr. Larson, Dr. Riddle, Dr. Curry-Winchell, Dr. Pasternak. We thank you not only for your service during the resurging pandemic, but also for dedicating and carving out so much time on this call. And I want to leave everybody who are still here with a very important closing opportunity. It is one of the stated purposes of this office to provide resources that our community can put to immediate use. And in order to do that, we're going to be providing you with the recording of this webinar, as I've already mentioned, and it's going to be complete with captioning, and we're going to be extracting a lot of the resources that we found placed in our chat box and throughout the Q&A. And if there are any questions we didn't answer, we will make sure to have them answered and shared with you. But what's most important, beyond even the fact sheets and the flu vaccine awareness campaigns that we'll be sharing from our friends from Immunize Nevada, is what I call the office's secret weapon. And that is Ms. Alyssa Howard. She represents the minority health consultants. And Ms. Howard, would you please introduce yourself and take a moment and talk about how you are doing some yeoman's work in the community and what you can provide to people as it relates to the season of flu.
Thank you, Tina. I did not know that I was a secret weapon. That is awesome. My name is Alyssa Howard. Good afternoon, everyone, and thank you to all of the panelists. I learned a lot of information as well, as I'm still learning about influenza and the flu and vaccinations and things of that nature. I am a public health educator, but I've been in infectious diseases my entire career of 9 years. And so now I'm just getting into chronic diseases and also getting into the flu and knowing more information. So I appreciate you all for that. The question did come from me regarding the African-American community, because I am hearing a lot of information about, or just skepticism about how do we know that this is safe. So I appreciate Dr. Pasternak, Dr. Pasternak and Dr. Trudy Larson for answering that. I'm going to disseminate that information out into the community when I hear that. So I just wanted to say today, just really quickly, that I am the owner of Minority Health Consultants, and I'm currently working with, in partnership with the Southern Nevada Health District's Office of Chronic Disease Prevention and Health Promotion Department, along with Immunize Nevada. We are disseminating flu clinics into the Las Vegas Valley for this particular reason, because we think if we go to the people, then the people will have more information and health education behind it. I'm also a community health worker instructor for the College of Southern Nevada. So I actually did a flu presentation for my students last night, and they seem to know a lot of information. So basically my whole hope is to get as much information as I possibly can so that I can be that person that goes out into the community and shares that education information. So if you would like to set up a flu clinic for your organization, your faith-based organization, your church, or just a nonprofit of any nature, please contact me and I will get that set up for you. Thank you.
Put the slide back up with her contact. Oh, it's still there. Thank you very much. Well, everyone, I don't think we need to belabor the point. You've got a lot of information. And as I said, this information is much better shared than it is to be withheld. So thank you so very much to everyone, and stay safe and be on the lookout for version 2 on the subject of the COVID vaccine. Thank you. Happy Thanksgiving.